Desperate times call for desperate measures. This is especially true for many of us in healthcare, as we find ourselves adapting to new roles and new units, innovating to tackle a new disease while adjusting to a new surreal reality. Hence, in an effort to reestablish some degree of normalcy, we decided to resume the release of our episodes on the Neurocritical Care Society podcast. As I say, the show must go on, and at least now you can listen to something that is non-COVID related for the next 20 minutes. I hope you enjoy this episode.
Hey, podcast listeners, Al-Mufti here from Westchester Medical Center, New York Medical College, and this is another episode of the Neurocritical Care podcast. I've often wondered and asked mentors and mentees, what is wisdom? Google defines it as the soundness of an action or decision with regards to the application of experience, knowledge, and good judgment. But wisdom doesn't necessarily mean knowing everything. One of my favorite quotes comes from Norman Cousins, an American political journalist, author, professor, and world peace advocate, who once said, wisdom consists of the anticipation of consequences. How often have we said, let's maintain a MAP more than 65, or a systolic blood pressure less than 140 or 160, targeted a cerebral perfusion pressure of 70 or 90, or an ICP less than 22? We frequently try to select parameters and treatments that are most likely to help our patients based on our best understanding of their individual underlying pathophysiology. We strive daily to weigh the pros and cons or consequences of any clinical decision we make, becoming more accurate, precise, proactive, and impactful for each individual that comes under our care has always been our goal. Precision medicine carries the potential for reimagining the way we practice neurocritical care while focusing on predicting, preventing, and curing diseases precisely. I'm absolutely honored to be joined today by pioneers and founding fathers of neurocritical care, Jose Suarez, professor of anesthesiology and critical care medicine, neurology, neurosurgery, and director of the Neurocritical Care Division at the Johns Hopkins University, and Claude Hemphill, professor of neurology at Zuckerberg San Francisco General Hospital, University of California, San Francisco. We'll be discussing the review paper entitled Precision Medicine in Neurocritical Care that was published in JAMA Neurology. Claude and Jose, welcome, and thank you very much for joining us today on the Neurocritical Care Society podcast.
Thank you for having me.
Great to be here.
Fantastic. All right. So before we start, can I ask you guys to maybe set the stage for our listeners by briefly talking about why you decided to work on this opinion piece and what you sought to highlight?
Well, Oz, I feel like this is something I've needed to get off my chest for a while. I think what I and others have seen is really a confluence of three different sets of events. The first has been numerous clinical trials in neurocritical care conditions that have been either negative or shown a very modest impact of the intervention across a range of diseases from traumatic brain injury to intracerebral hemorrhage to subarachnoid hemorrhage and others. And these have largely tested interventions that are either specific physiological thresholds or surgical interventions that have focused on the concept of broad applicability and generalizability across all patients or most patients with that condition. And we haven't derived pivotal treatments from these interventions in these studies. But secondly, there are secular trends and observational studies showing that there are improved outcomes across many of these diseases. And there's a lot of work now that shows that organization of care makes a difference. Neurocritical care makes a difference. And so we have these sort of what I'd say is conflicting issues. People saying from all these trials, nothing seems to work. We don't have a treatment for a condition. But good care matters. So something must be working. Something must be making a difference. And then I would say perhaps it's a little bit of jealousy in seeing how precision medicine has unfolded in other fields like oncology, where the focus has shifted towards the biology of the disease driving the treatment. And trial design, applicability, implementation has really followed from that biology rather than saying, what do we do now or what can we do now? And this really, the idea for this paper really came from Gentle Threshta, who said, we should do a review article on precision medicine in neurocritical care. And as we started it, we found that there was such a lack of data that we had to switch the review article to a viewpoint piece.
If I had to add to what Claude just said, I was also very intrigued, and because this is a sexy topic these days. Like it looks like the entire world is talking about precision medicine, and I think what I really wanted to do is to get into it a little bit more and try to explain what is it that we mean in relationship to applications of precision medicine into neurocritical care. And as Claude just said, when we looked, well, there was really not a whole lot that we found, but therefore it became more important for us to write something about it and send a message. A simple message, as you can see, wasn't really that complex. We didn't want to delve into the details of complicated computational analysis or anything like that. We just wanted to tell people the way we really felt and where we should be moving the field forward.
Fantastic. So you mentioned early in the paper, and I personally agree, that most neurocritical care trials have been based on a one-size-fits-all approach. This has left us largely with neutral results regarding blood pressure management or surgical interventions for intracerebral hemorrhage, intracranial pressure management, and traumatic brain injury, and neuroprotection for stroke, TBI, and stroke spinal cord injury. Neurocritical care now finds itself at a crossroad, or perhaps an inflection point, regarding the clinical science and evidence necessary to know how to best treat our patients. What lessons have we learned regarding what works and what doesn't, and what should we consider incorporating in the future?
I think, this is a very important point here because, we've had a plethora of clinical trials, as we mentioned, that have not worked. However, we have found specific situations where we can probably say that precision does matter, meaning just narrowing down the population or perhaps applying a particular therapy to the people or the patients that really need it. I think that the best recent example, of course, is the explosion of data on the endovascular treatments for acute ischemic stroke, right? I think we all remember back in 2013, when the papers from the IMS-3, the publications from the IMS-3 and from MR Rescue were presented at the International Stroke Conference that showed that endovascular therapy was not effective. At least there was no difference between the intervention group and the control group. We learned very quickly 2 years later that what was happening is that patients were now being selected properly. And I think obviously incorporating newer techniques, in this case, such as the CT angiograms or CT perfusion techniques, we were able to show that by selecting the patients that would be most amenable to treatment, that we could prove that the therapy was actually very effective. And not only that, but the number needed to treat was actually very small. So I think that's what we need more of in neurocritical care. We need to select the patient the group of patients that we're most interested in. And for that, I think we need to join forces, of course. We need to get together and work collaboratively so that we can identify who those patients are. The other example that I can give you where we've shown that overall, if you looked at the entire population, the treatments were no different. That's the field of blood pressure management and intracranial hemorrhage. And I think we were able to show once we combined the data sets from the two largest clinical trials, both the INTERACT-2 and the ATTACH-2, and looked at individual patient sets, we were able to identify that there were some patients that actually benefited more than others. For instance, those patients who had a significant reduction by more than 60 millimeters of mercury within the first hour, those patients clearly did worse. And also the patients where we observed that there was a lot of fluctuation in blood pressure during the first 24 hours, they also did worse. Had we known that before ahead of time, had we been able to identify those patients ahead of time, I think we would have had a completely different result, and we would probably be talking about different type of treatments or approaches to those patients.
Yeah, I agree with Jose. I think the embolectomy experience is very powerful, and large vessel stroke is a neurocritical care condition, and we've targeted a highly biologically effective intervention, that is embolectomy, and coupled that with very specific patient selection based on the biology of the disease, and it works. I'm concerned that we haven't learned very much from some of these large clinical trials that have been neutral, at least if we take the sort of punchline, bottom line, saying there doesn't seem to be any benefit or the benefit is very modest. I think what Jose is talking about looking at specific individual patients is potentially very powerful, because I'm concerned that we may take potentially effective interventions and we're testing them in the wrong way and we're throwing them out and saying that they don't make a difference. They may actually make a strong difference in the right patient.
Terrific. No, I absolutely agree. I think that makes perfect sense. As we struggle daily to individualize a particular parameter or intervention, the fact remains that neurocritical care conditions are complex and multifaceted. What should precision medicine in neurocritical care specifically look like?
I think to me what precision medicine in neurocritical care should look like is for me to be able to walk into the neuro ICU, admit a patient, Mr. Smith, Mrs. Jones, that she can come in or he can come into the ICU and I could get a signal, or I could get an index or some message of some sort to tell me that Mrs. Smith or Miss Brown looks exactly like many of these other patients that had either a good outcome, no complications at all, or they looked like exactly like these other patients that either herniated or ended up having complications in the ICU. And this was something that I really never thought about until a few years ago when I was still in Houston, and we designed a brand new neuro ICU, and at the time we were collaborating with some of the NASA investigators, and I was very proud and brought them into the ICU and showed them all the equipment that we had, because in my mind, our ICU looked like a space rocket, right? And then they were not impressed. And so I was really disappointed, and they were looking at me and they said, well, Jose, yes, I see you have very nice equipment here, but I could see very easily that this equipment X doesn't communicate with equipment Y, and equipment Y doesn't talk to equipment T or S. So how do you know that, that what you're doing is actually having an impact? And then one of them went even farther, and I said, well, this is what we used to do when we started planning to go to the moon and building all the rockets. We didn't have all this equipment. All the equipment did not talk to each other until we had to get engineers in the field and start working on this and trying to make them communicate so that we could send a unified message to the pilots or the astronauts or whoever was manning that rocket, so that they knew where they were going. And then I said, you know what? I think you're correct. I mean, if we bring 10 nurses here and 10 physicians, probably each one of them is going to come up with a different plan for that patient based on what they see in the monitors. So then I said, well, maybe that's where we need to go, and that's what precision medicine should probably look like. That we should have many collaborators, from across the globe that will be able to share data with us, and will be able to build algorithms, predictive algorithms that can tell us what our patients look like or are going to look like later on, so that we can anticipate rather than be reactive. I think we probably need to be proactive. I need to know whether 4 hours from now, Mr. Brown is going to look exactly like the Mr. Brown that he looks like now, or is he going to look completely different? I need to have some other type of intervention or how to treat him differently.
I love it. I completely agree with that. It's essentially, we're asking our neuro ICUs somehow to give us the wisdom to anticipate the consequences before they necessarily happen. So we're essentially prepared ahead of time before things collapse, and now we're struggling to treat a patient who's crashing. Although there may have been some signs, had we been able to analyze and incorporate them within a larger algorithm, we may be able to have predicted who was going to deteriorate and who was going to do really well.
I think we're talking about something that's really important, because I think this is one additional aspect of it is, at its core, precision medicine it's a change in philosophy from the current approach, and having providers sort of understand that and approach patient care in this way will be important. Precision medicine is really patient-centered care. It's not population-centered care, and we have to consider what we can do now while we're moving to the future. So we may start with a one-size-fits-all threshold-based guideline for a particular parameter, But I think if providers understand and avoid sort of the false assurance that that is somehow perfect or right at all times, and then think about how they might individualize therapy, then there's a willingness to consider how we implement new things as we go along. And it sort of becomes part of the mindset and appropriateness of care for physicians and nurses as well. Finding ways and thinking all the time, how are we going to individualize the care in this patient in a way that makes sense?
Terrific. In your paper, you guys put forth 5 principles that may serve as a general template in allowing us to transition our current practice or current approaches to a practice where we are utilizing precision medicine in neurocritical care. Can you guys elaborate on that?
Sure. We thought it was important to lay out some ideas on what are sort of the various domains that we think will need to be addressed. So rather than saying something very specific, such as we need data analytics to look at area under the curve, I think we needed to take a step back and think really about how we're going to redesign the way we look at research, clinical care, and collaboration in order to enable that. Because we've actually invested a lot in our current system, developing standardized guidelines, doing these large, expensive, sort of one-size-fits-all trials, and emphasizing that approach. So in some ways, we have to really think in a way of how we are going to redo it. And so the 5 aspects of the platform that we sort of laid out are, first of all, expanding systems biology research. And this is really the idea of taking a step back and trying to understand specifically what's the biology and the biological targets that we're trying to identify, because these are going to form the basis of then doing randomized trials. And this kind of goes back to this quote that I just particularly like from David Menon, where he says, we have to make what's important measurable rather than make what's measurable important. Just because we can measure blood pressure doesn't mean that it's going to be the right biological target. I think the other one is accept small successes. And my own bias is that we have tried to shoot too high, and by asking things like, what is the minimal important, clinically important effect in order to change clinical practice, I think in some ways we may have missed potentially important effects that open the door to the next step. We need to accept small successes, and we need to realize that treatments may not be widely generalizable, but as with the example of endovascular embolectomy, it does not work in all 800,000 patients who have stroke in the United States each year. But in the patient that it's right for, it works very, very well, and it matters to them. Then I think the other is design and test targeted intervention strategies. In no way are we suggesting that we're throwing out the concept of evidence-based medicine. Rather than that, we're really trying to come up with what's the right biological target and what's a highly biologically active intervention that's going to focus on that. And this is where my concern of thresholds means maybe that's not going to be the right answer across patients. And then make it user-friendly, which goes back to something that Jose was talking about implementation in the ICU. This is really important. And one of the things that I think people may not realize is we do this already. We do it all the time. Consider the example of the CAT scan, the CT scan. CT scan is a computerized assessment of numerical values, but because it's turned into an image, it can be easily interpreted by physicians, nurses, and we can even show our patients or their families, and they can get an idea of it. That type of user-friendliness is transformative, and we have to really think about that because we are dealing with a very complex situation. And then finally, the concept of working together. And the reason this is important, I think first and foremost is if we're moving from a one-size-fits-all to an individualized, personalized medicine approach, what we mean is we've got a wider set of treatments that are going to be potentially effective in individual patients or individual groups of patients. So if we're going to test this, we need lots of patients. And so we're really all in this together. I also think that this provides the opportunity to think about what we call comparative effectiveness research to look at what are our current practices and how difference in practices may inform us on what actually makes a difference. Bringing us all the way back to that concept of good care matters. How do we identify what that good care is now? So by thinking about these 5 general themes, we hope that we can empower us as we think about our protocols, write our grants, do our trials. Maybe we can consider these as being important ways we design the way we move forward.
Yeah, I completely agree with what Claude just said, and in fact, this is where we spent most of the time when we were trying to complete that position paper, that opinion viewpoint in JAMA Neurology, because we wanted to make sure that the message was clear and simple. And I think I would like just to stress the point of making it simple. Okay, I think if we always forget, obviously the simpler we make it, the better. Think about when you get called at 2 o'clock in the morning, right? You're half asleep, trying to wake up, trying to figure out who's calling you, and then you get either a nurse or you get a resident on the phone or a fellow trying to explain to you what's actually happening to that patient. Wouldn't it be nicer that they can just send you something, an image or a picture or a graph or something that would explain it all very simply, and then you will get it right away rather than spending half an hour trying to figure out what is it that they're trying to tell you. I think that would be important too, so you can make decisions much faster.
Absolutely, and I think that's terrific. No, thank you guys very much. This was excellent. And honestly, this paper was, to your point, very simple, very easy to read. I think it drove home the message really, really well. Jose, I have a question for you. What are some of the potential challenges that we may face over time, and over what time frame do you envision this occurring?
Yeah, that's a very good question. I think one of the main challenges that we face is that of collaboration across disciplines, and by that I mean I think we need to work harder, more intimately with our nurses, right? With the nursing staff. I mean, think about this, they spend most of the time at the patient bedside, and yet we design the clinical trials, and most of the time we don't even take into account nursing care. Okay? And they're doing all the work at the bedside. From what we know, maybe turning patients every 2 hours could be harmful, and we're not even thinking about that. And we have to think, who are the patients that could be turned every 2 hours, and who are the patients that cannot be turned? And maybe that may be even more impactful than trying to come up with a new medication for a particular patient. So I think that's our challenge, and I think we have to do better. We have to collaborate more closely and pay attention to what we're all doing in the ICU. It's not just what we're doing, but also what our colleagues are doing, and in this case will be our nursing colleagues who are spending most of the time at the bedside. The other challenge I think that we have to overcome is perhaps to come up with better ways of monitoring our patients, and by that I mean maybe coming up with more non-invasive ways that could tell us a lot, because by doing non-invasive technology, then we don't have to depend on other practitioners or other professionals to help us. For instance, intracranial pressure monitors, right? Is there a way that we can actually do that non-invasively, so that we can place the monitors at any given time without having to rely on somebody else to come at the bedside and place a catheter to measure the intracranial pressure? And even, we can also do this in less resource intense environments, so we can have a richer data set so that we can come up with better conclusions and better applications for our patients. I think one aspect that I'm very hopeful that we can get there. Now, I'm thinking the time frame that you asked me, I was thinking maybe within the next decade, I think we should be able to get there, to collaborate more, to do things in a less invasive manner. And the reason why I'm saying this is for 2 reasons. One is obviously the Neurocritical Care Society, right? We have grown significantly, and I think we have shown that we can actually work collaboratively, and we have collaborated in every single aspect today of everything that we do. I think that that's very helpful. And the second point, I think one thing that can help us also get there is that I think there is also interest at the level of scientists in other fields doing things less invasively that can collaborate with us. One specific example is, of course, space travel, right? So now we're thinking about going even farther, into space, going to Mars, and some of these astronauts are having problems with intracranial pressure. So this is all neurocritical care. So obviously we think that that's going to help us because there's going to be funding that is going to be allocated to research in that area. And of course, as you know, it'll be difficult to place an intracranial pressure when you are millions and millions of miles from Earth. That would be kind of difficult to do. Besides, we don't know what the consequences of that might be. But the non-invasive way to monitor that would be something that could be also applied there. That's why I think that the field is going to move much faster than we anticipate. And I think probably in the next 10 years, I think we're going to have a very different neurocritical care practice than what we're seeing today.
Wow. It is undoubtedly an exhilarating and very exciting time to be in neurocritical care with tremendous progress in research, education, patient quality, and advocacy and training. Finally, I wanted to spend a few minutes trying to tie in the concept of precision medicine and the Cure and Coma campaign. Why did the society embrace Cure and Coma campaign as an integral part of our mission going forward at this particular stage? And what does Cure and Coma mean to you?
This actually really came out of almost 2 years of strategic planning, thinking about the role that the Neurocritical Care Society could take in neurocritical care research and should take. And a number of the things that we talked about that really led to the writing of this viewpoint on precision medicine really informed us as we were thinking about this going along. We had the conference at the 2018 Neurocritical Care Society meeting. We had the Blue Ocean Conference, and that was really a research strategic planning meeting that coalesced a lot of these thoughts. And just as a reminder, Blue Ocean is actually a business term thinking about uncontested market space. But from a research standpoint, it was really untapped issues that were relevant very broadly to the field. I mean, we all know neurocritical care is complex, and there's so many different issues that we have to address every day in our patients. And one could say we need to understand what's the right day to start venous thromboembolism prophylaxis. What is the right day to start feedings? But there's so many questions here. But when we step back and really thought about it, at the core of what all of us and our bedside nurses and everybody that are neurocritical care providers addresses each day, what do I get asked every day? What comes up? At the patient level, most common set of questions are they going to wake up? When will they wake up? How well will they wake up? What can we do to help them wake up faster and better? Really, this disorders of consciousness and altered consciousness is really the key fundamental thing that crosses so many of the diseases that we treat, most of them. So when we thought about the Cure and Coma campaign, the idea really was a grand challenge that would unify and galvanize and tap into the really broad resources that providers and members of the society bring. So we're kind of thinking about coma writ large. We use the term coma because it's a nice way to summarize it. But really we're talking about acute disorders of consciousness and all those questions that happen and that come up. So, these issues really transcend these diseases. And in many ways, I would say they probably define neurocritical care as a field. So taking sort of a two-pronged approach and really trying to move the science forward and really harnessing what we call in the Cure and Coma community, which is all of us, anyone that wants to have a place in this, to think about how we improve education, advocacy, and implementation. That's what it's about. But I guess I would say for me, Cure and Coma means being able to understand the biology of why a specific patient has altered consciousness. That may be circuits or lesion or physiology, but the specific biology in that specific patient, being able to understand whether it's amenable to intervention and then developing interventions to target that biology for that specific patient's issue.
Yeah, I agree with what Claude just said, but also, I think we also need to understand that. I think we knew this when we came up with this campaign, that because we know this is the new research focus of Neurocritical Care Society, right? So this is where we want to go. This is how we want to be known in the future for. And we know that the road is long, right? But I think because this is about everyone in neurocritical care coming together, right? So we want every single person that comes in contact with a neurocritical care patient to say, I want to help solve this problem. Okay, I want to help you. And I think that's what we were thinking. And it's great to see that we've had all these great group of collaborators and people that have been so enthusiastic that it's actually moving fairly quickly, much, much faster than what we thought. And we haven't heard from any of them any issues regarding to egos and regarding to I want this space for me and not for you. On the contrary, I think what we witnessed is an explosion of camaraderie and collaboration and everybody trying to come together to answer this question. And I think for me, it's essentially for me specifically be able to come to meet families and be able to tell them that, yes, their loved ones are going to wake up. And I know because we did all this research already and we collaborated with all these people, with all these investigators, and we came up with newer treatments and we're able to tell you that your loved one is going to be just fine, even if it's in coma now. Or maybe the other way around, we can also say, you know what? Maybe your loved one is never going to wake up or is not going to do well, but I think hopefully we can help them make better decisions for their patients.
Fantastic. It was absolutely a pleasure speaking with you guys. I can't wait to see what the future holds for neurocritical care and for neurologic emergencies. I want to thank you guys so much for your time. It was probably one of my favorite episodes to record.
Thank you very much for having us.
Great. The future is bright.
Excellent. Terrific. Thank you all for listening to this episode.
With continuously updated content on topics ranging from acute ischemic stroke to clinical evaluation of coma and brain death, prognostic assessment, and traumatic spinal cord injury, Neurocritical Care On Call is the only product of its kind to offer content exclusively dedicated to the practice of neurocritical care. This interactive, subscription-based website features tables and figures, videos, author insights, and sections specific to nursing, pharmacists, and APPs. To learn more about subscribing to Neurocritical Care On Call, visit www.neurocriticalcare.org/on-call. Use promo code PODCAST for an extra 10% off your subscription.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Ramani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Sternnezer, and Chris Zammit. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.